Hello, my name's Tom Stinchcombe. I'm a medical oncologist at Duke Cancer Institute, and I specialize in thoracic oncology. My primary focus is on clinical medicine and clinical trials and bringing novel therapies to patients. And it's my pleasure to join you today. So we've been chasing MET alterations for probably about 10 or 20 years. Most of those years were unsuccessful. I think part of the problem is we didn't know how to define MET positive lung cancer. Was it by a protein overexpression as measured by IHC? Was it by amplification? And eventually we settled on something called MET exon 14 splice alterations. And what these are, there are about 140 alterations that contribute to this molecular outcome where the MET receptor is not degraded at the same rate, so it's sort of stuck in the on position and leads to cancer growth. Our initial studies showed crizotinib had some activity in this disease because crizotinib was developed as both an ALK inhibitor and a MET inhibitor. But more recently, we've seen more potent drugs. The drug cabozantinib was recently approved. And there's another drug, tepotinib, that was published in the New England Journal that we expect approval in 2020. And so I think there are going to be the next generation of MET inhibitors available. When I looked at the MET exon 14, I think the median age is around 70. So historically, with some of the mutation types, we always get fixated on the young, never smoker, but this is an alteration that's very common in elderly patients. And I think that sometimes this can be a very aggressive disease. And I think it illustrates that we really have to do broad next generation sequencing of all patients to make sure that we don't miss someone. And then I think the critical thing too is you actually have to make sure that your next generation sequencing panel includes the MET exon 14. For instance, our internal panel at Duke does not include this, so we've had to pursue next generation sequencing through outside vendors.